The arm went weak. The words stopped, or the face felt strange on one side. Minutes later, it was completely gone. Those are stroke warning signs. Being sent home is not the same as being safe. When symptoms arrive and vanish, the body is signaling something still in progress, not something finished. What the next 2 days include or skip determines what happens after. By the end of this video, you'll know the specific words that change what gets ordered, the one test no one can dismiss, and exactly what to do every day that passes after stroke warning. Symptoms without the right evaluation is time working against you. Here's what that window actually means, starting right now. Margaret was in the middle of a sentence when it stopped. She was at her kitchen table talking to her husband when her right hand went numb, not tingly numb. The words she was reaching for simply stopped, not slurred, stopped. For 3 minutes, she couldn't form what she was trying to say. Then it passed. Her hand came back. Her words came back. She felt completely normal. Margaret was 74 years old. Her husband said she was probably just tired. Her primary care doctor said it was most likely stress. A follow-up appointment was scheduled for the following week. If you or someone you love has had an episode like this, something that came on suddenly, lasted a few minutes, then resolved completely, and a doctor sent you home with some version of "you're probably fine, you're getting older," this video is specifically for you. Because here's what the research says about that dismissal. An American Heart Association scientific statement published in January 2023 found that nearly 1 in 5 people who have a suspected TIA, a transient ischemic attack, what most doctors call a mini stroke, will go on to have a full-blown stroke within 3 months. What that means is being sent home with it was probably nothing isn't the same as being told you're safe. The dismissal itself is the danger. And there's something about the 48 hours that follow an episode like Margaret's that almost no one explains, something that changes the outcome dramatically. What you do in that window, who you call, and the specific words you use aren't small details. They're what this video is about. The people who never hear this keep waiting for that follow-up appointment. The ones who do hear it make one phone call, and that call changes what happens next. Here's exactly what is happening, starting with what that dismissed episode actually means for your body right now. At Healthy Aging Watch, every video is built from peer-reviewed clinical research. Every source behind what you're about to hear is PubMed indexed. You'll find them in the description. What the research shows specifically about episodes like Margaret's is that the 48 hours after they happen aren't a waiting period. They're a decision window. Have you or someone you love had an episode like this, something that came on suddenly and then resolved, and a doctor sent you home without a clear answer? Tell us in the comments, and before your next appointment, write down 2 things: exactly when it started and exactly how many minutes it lasted. Those 2 details change what happens next. Think of your brain like a city with thousands of roads. A temporary roadblock, one that clears in minutes, still tells you something is wrong with that road. A cleared roadblock isn't a safe road. That's what a transient ischemic attack is. The medical name is long, so doctors shorten it to TI. What it means: a brief blockage in blood flow to part of the brain, short enough that symptoms resolve on their own. The blockage clears, the symptoms pass, the brain appears fine, but the road isn't fine. This is what the speed of evaluation does to your risk. The Express study, published in The Lancet, tracked patients after TIA-like episodes. Patients seen the same. Day had a 90-day stroke rate of 2.1%. Patients whose evaluation was delayed by just 3 days had a rate of 10.3%. Same patients, same symptoms, same health history. The only difference was how fast they were seen. What that means is the single most powerful factor in whether you have a stroke in the next 3 months isn't your age or your health history. It's how fast you're evaluated after the episode happens. The phrase to use is rapid access TIA clinic. Not "I had an episode," specifically. Is there a rapid access TIA clinic I can be seen at today? Margaret said she had had a neurological episode and needed to know if there was a rapid access TIA clinic she could be seen at today. Those words changed which question got asked next. A rapid access TIA clinic is a same-day or next-day evaluation service designed specifically for people who may have had a TIA. What makes it different from a standard follow-up appointment? Everything happens in one visit: brain imaging, a heart rhythm check, blood tests, and a neurological exam, all coordinated the same day. It exists because stroke risk is highest in the first 48 hours after an episode, and a follow-up appointment scheduled 3 weeks out means waiting through the window when an intervention changes the outcome. Not every hospital uses that exact name. Some call it a stroke fast track or TIA pathway, but using the words rapid access TIA clinic tells the person answering the phone that this is time sensitive. The question shifts from "can you come in next week?" to "can you come in today?" Now there's a more dangerous pattern, and it's almost always missed. Researchers call it capsular warning syndrome. If the same thing happened more than once in the same day, the same hand went numb, the same words stopped, the same eye went dark, and each time it passed, that repeating pattern carries a 7-day stroke risk of approximately 60%. That figure comes from a population study published in the journal Neurology. A separate study published in BMC Neurology found that more than 80% of people with this repeating pattern had real tissue injury visible on the right type of brain scan, even though their symptoms had fully resolved. A single mild episode that resolves is an emergency. The same mild episode happening 3 times in one day is a different and more urgent emergency. If that's your situation, go directly to the ER. Say this happened 3 times today, same hand, same side, each time it resolved. This is a repeating pattern, not a single episode. Emergency physicians use a scoring tool, the ABCD2 score, to decide who to send home. A pooled analysis of nearly 10,000 patients published in the journal Stroke found it predicts stroke risk correctly roughly 3 times in 4, meaning 1 time in 4, it gets it wrong. A low score isn't proof nothing happened, and it underestimates risk for repeating episodes. If you were sent home after a scoring tool was used, ask what the score was and what other tests were run. A score alone isn't a complete workup. A standard CT brain scan rules out bleeding. It can't find injury from a blood clot that already dissolved. A specific type of MRI can find whether there was real tissue damage, even when every symptom is gone. A 2024 review in the Journal of Stroke and Cerebrovascular Diseases found that approximately 1 in 4 people whose symptoms had fully resolved still had measurable injury visible on that specific scan. A normal CT means there was no bleeding. It doesn't mean there was no injury. The question to ask, has an MRI been ordered, not just a CT? Those are not the same scan. One more piece, heart rhythm. Atrial fibrillation, an irregular heartbeat that can throw small clots toward the brain, is a major cause of stroke after a TIA. A standard 24 to 48-hour hospital monitor has about a 3% chance of catching the most common type in people over 70. This rhythm comes and goes. It can hide for weeks between episodes. The Crestall-Aff trial, published in the New England Journal of Medicine, tracked people whose stroke had no identified cause after a standard workup. With short monitoring, about 3% had atrial fibrillation detected at 3 years. With extended monitoring over the same period, 30%. Same patients. 10 times more found. What that means is atrial fibrillation can hide for weeks between episodes. A 2-day monitor that comes back normal isn't proof the rhythm is healthy. It's proof the monitor wasn't running during an episode. If your post-episode heart monitor came back normal after 2 days, that's not a clean heart finding. That's an incomplete monitoring window. Ask specifically for extended cardiac monitoring, 21 to 30 days. Here's the language that changes what gets looked at next. Write down what happened in 4 parts. When it started, not Tuesday afternoon, but 2:15 p.m. Tuesday. How long it lasted, not a little while, but about 4 minutes. Which part of your body, not I felt strange, but my right hand went numb. How it ended, not I felt better, but it resolved completely. Those 4 elements change whether a workup happens or a follow-up is scheduled 3 weeks out. Before that next appointment, check one thing. Look in your medicine cabinet. If you see ibuprofen, Advil, Motrin, Aleve, or naproxen, and you're on 2 or more blood pressure medications, those medications may not be doing what anyone thinks they're doing. Those pain relievers block an enzyme called COX, cyclooxygenase, that helps keep blood vessels relaxed and helps the kidneys clear fluid. What that means is when that enzyme is blocked daily, blood vessels tighten and the kidneys hold on to more fluid, and blood pressure rises and stays up. A clinical review published in Drugs and Aging found that daily use raises blood pressure by nearly 5 points on average in older adults already on multiple blood pressure medications. The result can look like blood pressure that is hard to control despite 3 medications. Margaret had been taking ibuprofen twice a day for 11 months. Nobody connected it to the episode at the kitchen table. If your blood pressure medications include a beta blocker, metoprolol, atenolol, or carvedilol, or an alpha blocker used for blood pressure or prostate symptoms, doxazosin, terazosin, or tamsulosin, there's one more test to do. Sit for 2 full minutes. Take your blood pressure reading. Stand. Recheck within 1 minute. A drop of more than 20 points in the top number means blood pressure dropped when you stood, and that drop can cause the same arm weakness, the same speech difficulty, the same visual change as a stroke event, then resolve on its own. Margaret's drop was 28 points. Write down both numbers. That specific measurement is what a pharmacist or cardiologist can act on. A description of dizziness can be dismissed, a number written down can't. If you take glipizide, glyburide, glimepiride, or insulin, the first thing anyone should check is your blood sugar. When blood sugar drops too low, it can cause the same sudden arm weakness, the same speech failure, the same confusion as a stroke, and it resolves when the sugar comes back. Ask for a blood glucose check before imaging. It takes 30 seconds. If you're on a blood thinner, warfarin, Eliquis, or Xarelto, and a procedure requires stopping it, some doctors prescribe injectable blood thinner shots during the gap while the pill is paused, a practice called bridging, to maintain protection. The BRIDGE trial found that for most people with atrial fibrillation, this bridging adds significant bleeding risk without reducing stroke risk. Bridging is now reserved for mechanical heart valves, a stroke or TIA within the past year, or a very high-risk score. The question, am I in that group, and how fast does my blood thinner restart if you take Plavix, clopidogrel, and a procedure requires stopping it? Platelets can rebound when Plavix stops suddenly. Ask whether the procedure can be done while staying on aspirin, and how fast Plavix restarts after. Bring every bottle to your pharmacist, OTC included. Here's what happened to Margaret. Her daughter brought her to the pharmacist that same afternoon. The pharmacist reviewed the full list: 3 blood pressure medications, 11 months of twice-daily ibuprofen. The sit-to-stand blood pressure check showed a 28-point drop. He documented the interaction and sent it to Margaret's cardiologist directly. Her cardiologist arranged a same-day evaluation. Imaging found moderate narrowing in one of the arteries in her neck. She stopped the ibuprofen, and her doctor reviewed her medication regimen. 8 weeks later, her sit-to-stand pressure drop was 11 points. Her knee still hurts. She takes acetaminophen now. She hasn't had another episode. Margaret's story isn't every story. The imaging found something. Not every workup does. What changed for her was the pharmacist visit that happened before the next appointment was ever scheduled, the number written on paper, the words she used when she called. This is general health information, not advice for your specific situation. For your own case, speak with the physician who knows your full history. You're now the person who knows what the dismissal actually means. The specific test that produces a number no one can wave away, the name of the clinic that cuts your risk 5 times over, and the 4 words that change what happens at the next ER visit. If someone you love has had an episode that was sent home as nothing, share this before 48 hours have passed. That window is when this information matters most. We get messages every week from viewers who had an episode like Margaret's, were told it was probably stress, and found this video in the days that followed. If that's you or someone in your family, pass this on. The 48-hour window is real, and it's still open. Next week, the one blood pressure reading your doctor takes that may not reflect what your pressure is actually doing at 3 a.m., and why nighttime pressure is the number that matters most for stroke risk after 70. Right now, notice whether your hands are warm. That's circulation doing its job. We'll see you there.